Good afternoon, everyone, and welcome back to the Be Well Texas Systems and Sustainability Echo. My name's Andrea Roche. I'll be moderating and facilitating our conversation today. Just a few quick housekeeping notes before we get started. These sessions are enabled for closed captioning. If you want to view closed captioning, just navigate to the bottom of your Zoom window and over to the right, select Show Captions. You may need to click on the three dots or the More menu on the bottom right corner of your Zoom screen to find the option. If you're having any trouble accessing those features, just chat with Kato at UT Echo IT. As you saw at the beginning, we are recording these sessions and make them available afterwards through the Be Well Texas YouTube channel. Know that any information you put in the chat is not going to be shared on those recordings. As always, we do ask if you stay muted, that you stay muted unless you're speaking. That said, we encourage everyone to speak and share in today's conversation. To mute and unmute, if you've joined on a computer, just select that microphone icon on the lower left of your Zoom screen. If you're on the phone, press *6 and wait for a very loud voice to tell you you've been unmuted. We are happy for you all to participate in any way you see comfortable in today's conversation, whether that's muting, unmuting, and speaking up, or sharing your perspectives over in the chat. Just know that at no time during the session is protected health information allowed, either in the chat or in the conversation. There are a lot of us here, so please do keep your comments brief to allow others a space to speak up as well. To help us also with attendance, since there are so many people here, please use that chat feature to enter your name, your affiliation, and your email. To access the chat feature, again, go to the bottom of your Zoom window and click on that speech bubble icon. A special note to all Be Well Texas providers, we want to make sure we acknowledge and record that you're at these sessions. So make sure you identify yourself in the chat. If you joined on a phone, we don't have a good way of tracking who that is. So email the Be Well Texas team your phone number and that you've attended this session. Actually, don't think we have many call-ins anymore, but like to do that just in case. Keep an eye on the chat. Towards the end of the session, we're going to send out a link to an evaluation survey. Fill it out for a couple of reasons. It enters you into a drawing to get a Walmart gift card, I think to the tune of $30. But more importantly than that, it allows you to give us some feedback on where we can take these sessions to better meet your learning priorities and your needs. So we're really excited about today's presentation and discussion. We have a didactic offering an update and a refresher on substance use disorder treatment ethics. And then following that, we'll discuss a case presented by Abilene Absolute Recovery Systems. We're going to start our session, as we usually do, with some introductions of our hub team and presenters. And then we're going to get into those didactics, have some time for Q&A, announcements from the Be Well program, and then our case presentation and discussion. Again, remember, Echo is a space for all of us to learn and all of us to teach. So we look forward to all of you sharing your insights and your perspectives into today's conversation. With that, we're going to do some introductions. Cathy, I'll start with you.
Hello, everyone. Welcome to our Echo. I am a integrated care program building and implementation consultant, and my background, I have a PhD in marriage and family therapy, and I'm a licensed professional counselor as well. And I've been working in integrated behavioral health care and substance use treatment disorder integration for almost 2 decades now. Thank you for being here.
Thanks. And Matt.
Hi, everybody. Welcome. I'm Matt Rosa. It's good to be with you. I'm a consultant. I work in quality improvement, process improvement using the NIATEX model. I work on a lot of implementation studies and with SAMHSA-funded technology transfer centers doing technical assistance and coaching. Background is in clinical social work, agency administration, and governmental planning.
Thanks for joining us. Leslie.
Hello, everybody. I'm Leslie Manson. I'm a licensed clinical psychologist. I'm also an integrated care trainer, consultant, educator. My specialty is in integrated care development, implementation, auditing, and the development of fiscal sustainability. Thanks, everybody.
Thank you. B.
Hi, good afternoon, everyone. My name is Bidi Seda, or B. Courtois. I am with UT Health San Antonio, and I've been in the field of behavioral health services with a heavy focus on substance use treatment services for about 28 years now, whether that's building programs, working in programs, or running programs, just kind of the full gamut. And I'm happy you're here. Thank you.
Thank you, B. And I think I saw you. Adrian, are you there?
Yes, sorry, I don't have my camera on. I'm in between meetings, but hi, everyone. It's nice to see you again. I'm Adrian Lindsay, Director of the Center for Substance Use Training and Telementoring. Thanks.
Thank you for joining us. And then to our case presenter for today, Jasmine.
Hi, I'm Jasmine Mikowski, and I have a doctorate in leadership. I taught for 20 years and live in rural West Texas, and decided that we needed some assistance out here. And so I will be talking today about how we are struggling out here in the rural areas, transportation for our patients, and also just the leadership and grit and determination it has taken to start a new clinic in the midst of being in rural West Texas and also in the midst of a pandemic.
That's a great teaser for conversation to come. Jasmine, thanks so much for sharing with our group today. Well, just a reminder to those of you who are filtering in, please do use the chat to introduce yourself with your name, affiliation, and email. We're going to go ahead and take it away with our didactics. Cathy, when you see the screen, get started.
I'm ready. All right. So welcome again, everyone. Next slide. We're going to be talking about substance use disorder treatment ethics today, just a little bit of a refresher on some of the emergent issues, and also team-based care approaches to decision making. This little bit of disclaimer, I am not an attorney. I hold no responsibility to any guidance or policies that you take on or actually assume from this presentation. I'm always very conscious of the fact that you have your own risk management, and you should always consult your own legal and risk management folks when making a decision about any patient care. Next slide. And here are learning objectives. I think you had those before. So I'm going to move on. Next slide. So as all of you know, and maybe you have a different experience than I've had or with the folks that I've worked with in the past, but substance use treatment is hard work. And the policies and guidance and all of our standards of care are in place to help this work be easier on the patient and on the providers and the staff and teams. We actually had a case a couple echoes ago where the person said, why can't we just make this easier for everyone? And we just really, that resonated with our team in particular. And that is the sort of the purpose behind these standards, these guidance, the legal regulations, all of those are in place to make this clear and easy. Well, it doesn't always work that way. But how are these practice policies built, especially in your own organization? So as we know, the most restrictive policy, regulation, or guidance is the one that we typically have to practice under. It starts with federal law, and that for substance use disorder treatment is HIPAA, and then 42 CFR Part 2 are typically the most guiding factors. State law can be more restrictive, but cannot be less restrictive. Agency and organizational policies typically become even more restrictive, as you know, because those are guided by things like risk management. And then the ethical guidelines enter into some of those policies, but not always. And those standards of practices usually go to are really deferred more to the risk. So anything that would change the ability to be certified or be reimbursed, those usually guide those organizational level policies that are the most restrictive. Next slide. So with all of that in mind, sometimes the guidance and the policies and the regulations are conflicting, or they don't take into account ethical guidelines for many of your staff and providers. And that results in a tug of war. Next slide. with a patient caught in the middle. Just a quick check-in before I dive in here. Am I talking in a vacuum here where this has only been my experience, or have any of you, if you want to just raise your hand or just, put something in the chat, have any of you all felt any of the tension or conflict between those policies, regulations, and your own ethical guidelines, or your team's, dynamics in the way in which you're having to negotiate some very difficult ethical decisions? So we've definitely, almost every day, Aisha, hey, Aisha, good to see you almost every day. Yes. So navigating those quandaries and dilemmas are usually driven first by your organizational policies, and then anything that would be under or up to interpretation by each provider, and then also overlay of your own ethical guidelines. That's where your tension and conflict usually comes in. I'm going to just really quickly give you an example. When you have team members, and we are doing a lot more team-based care when it comes to our substance use disorder treatment approaches, you have some of your team members who have ethical guidelines, and they are professional guidelines. And then you have some who do not have professional ethical responsibilities based on the way they are trained or their function. So you may have staff members who are, hired just to do case management, who don't have certifications, who don't have those kinds of professional responsibilities. And when I'm talking about ethics, I'm talking about those professional principles that govern a person's behavior and actions within the role that they are playing in that team. So you'll have case managers, or even not even on the management team, you may have people who are helping negotiate transportation. We'll talk about that later in an organization. And they don't have the same ramifications if they step around those ethical guidelines. They won't lose a license or a certification. There will be no, outcome that would be adverse. Next slide. So with that in mind, I thought about looking at the most common addiction treatment professional ethics that sort of intersect regardless of the type of provider or staff that you are. You could be a prescriber, you could be a therapist, you can be a certified substance use counselor, whatever your role is, a peer support, a community behavioral health worker. So when you start intersecting these, even if you have an LCSW, or if you have a psychologist, or if you have a nurse practitioner, whatever you call it in your organization or state, patients' rights and autonomy usually is one of the driving principles. That's one of the ethics. You keep that in mind for every action and policy and the things that you do on a daily basis in your practice. Integrity, honesty, and trust, it comes up almost every time when you start looking at any even guilds or certifying or bodies like, NADAC, any of those. But honesty, integrity, and trust, very important. Competency, you work within only your competency of your practice. So at the top of your license, but not past your own competencies. Therapeutic and team relationships are very important. So you maintain those within your ethical guidelines, restricting dual and multiple relationships, making sure that they're healthy, self-awareness of your own values and biases. And this is also includes your cultural awareness and your trauma-informed care. Ongoing professional development. This is increasing your own competencies to actually work with the patients and make sure that you're meeting their therapeutic needs. Confronting unethical, illegal, or incompetent practice, either within your own organization or outside of your organization, that anything that would influence your own patient care or your patient outcomes. Your social responsibility, this is also includes your cultural awareness, but also your ability to work with the other organizations in your community and making sure that all of the decisions you are making are ethical. This could also include some practice philosophies. We have a lot of conflict around harm reduction, and people will put this into this social responsibility category. And it depends on which side you're landing. Even medication-assisted treatment in general can actually, if you have a particular philosophy, can go under this. So people can be against this type of treatment and still feel like they are exercising their social responsibility. And someone who really does believe in this philosophy will actually be exercising the same principle. So can you see where the conflict happens? Because we all will put our perspective into these categories and really believe that we are exercising our ethical responsibilities. And then promotion, marketing, and business practices. I know that there are some controversies about some predatory business practices that have emerged based on a lot of the funding, and also some different I would say, approaches to substance use disorder treatment. And that has been opened up by many of the funding streams that have come out of the federal and state governments. So that's where some of it, and again, you know, this is very subjective in the way in which you evaluate it. Next slide. So for Texas, the Texas Association of Addiction Professionals, this is your code of ethics. These are the main principles. If you are a member, typically this is a systems organization, but also includes your professionals and providers. Anybody actually belong or is a member of the Texas Association of Addiction Professionals? Do we even have someone probably on the board? So this is one of the governing bodies in your state. And as you can see, there we go, we have someone. You can see that they intersect with those common addiction professional ethics noted earlier. I won't go through that, but you can see that there's some commonality. And I bring this up because we will be working with other team members who have a totally different set of ethics, and you don't understand why their decision-making is so quite different than yours. And it may be because they're focusing on a principle that is not included in yours. And I'll give you an example, even between behavioral health providers. There are some behavioral health providers that advocacy is one of the main principles that they work under. And so a lot of the decisions they will be making will be under that, you know, that category with that lens. And then you'll have another behavioral health provider where, you know, you're looking more at the idea, you know, looking at your treatment practice and, you know, do no harm may be what your primary principle will be. If you can imagine where you have a provider who is prescribing and they're looking at the practice guidelines, and you have another team member who is advocating for a patient because of things that you feel like is more important to them, where off-label prescribing should be important, there can be a lot of conflict. And I may be describing a conflict that I've only experienced, but I wonder if you all can apply the same understanding. If you go to the next slide, medical providers. So, you know, we typically have behavioral health team members who may be on the therapeutic side, and then we have prescribers in the medical field. And when you start doing team-based care, you're having, you know, you're intersecting these two different types of treatment cultures. You'll have, these are their 4 principles. So most medical providers have these 4 guiding principles, and a lot of the things that they do are under interpretation. So there's the American Medical Association actually gives them a little bit of latitude, whereas in some guilds, like for me as a marriage and family therapist and professional counselor, it's spelled out pretty clearly. But I do, my ethics also I'm sharing with those with autonomy, justice, beneficence, and non-malfeasance, they intersect as well. So I'm going to stop for a second. That's a lot, but if you can sort of understand that when you're working in a team, you may be, using different words, but you have the same principles that are in play. Any thoughts about that quickly? So does the concept of sort of understanding. So I bring this up because one of the things that I've noticed in team-based care is that we are typically not cross-training each other on why we are making a decision or why our perspective may be different. And that is key when you are trying to, resolve a quandary. Next slide. When in doubt, check it out. Love it, Julie. So let me pose some of these emerging issues that are disrupting some of the decision-making that we have tried to work out, prior to the pandemic. We have evolving treatment approaches and philosophies. This is where we have harm reduction. This is, if you can think of some of the other emerging medication-assisted treatment approaches, this, the inclusion of peer supports, that is, has been a wonderful, achievement in our staffing and has, I think, rounded out our treatment teams, but it also poses a different approach. Adoption of telehealth and technology. Oh my goodness. So we have quite a few limitations with telehealth that we had to negotiate and navigate, which caused quite a few ethical quandaries. So those exclusions seem to pose some challenges. And then the use of technology. I work with several practices that use internal messaging during patient care visits. And some of that information that would be considered patient health information is shared during that type of interaction. With the addition of the Cures Act, as you all probably know, patients have broad access to their patient health records. And that kind of correspondence, depending on how it's exchanged, may or may not be visible to your patient. And so those kinds of challenges have asked us to adjust our practice policies to make sure that we are not harming our patients, exposing any type of confidential information, or breaching any of our policies for patient protection. We are changing some laws. The 42 CFR Part 2, there is, and we can put this in the chat box. I can do that after I present. There are some proposed changes that will actually reduce those restrictions that make it more in line with HIPAA. The comment period will be up at the end of February, I believe. And so you still have time if you don't have that link. But those changes also change our policies. And during the pandemic, I know that the federal government noted that they were suspending some of the monetary penalties for 42 CFR Part 2 breaches, but that has gone back into place. Emerging staffing models, this is what we were talking about, the team-based care approach. This is where you get more people involved with your patient care, and many of them do not have the same parameters that we do on the professional level. Next slide. So how do you resolve these dilemmas as a team? Because as we've talked about, some of us have common ethical guidelines. We all share the most restrictive in our organizations, the policies and regulations. We are governed by our state and federal guidelines. Next slide. First of all, before you even look at your dilemma, having a framework will help. You can use your 4 principles, looking at the quandary and deciding, are we going to go with justice, which means that we want to make sure that everyone will get the same type of treatment. when we make a decision. So we're not going to exclude someone based on one of our own biases. Or do we go evidence-based practice? That's another approach that many organizations will use. Do we consider patient preference, our own clinical judgment, and do we defer to the literature and the most current practice guidelines? That's the 3 prongs of an evidence-based practice. So you can use whatever framework you need to use, but you first have to identify and break the specific ethical problem down. Sometimes everyone just assumes that you've got this problem. Like, do we allow this patient to continue treatment even though they've broken one of the, the rules that we have for their treatment protocol? So you have to hold it up to these ethical and regulatory guidelines. You identify any of the parameters that you cannot break, and then you acknowledge each team member's ethical codes or perspective. You've got to consider those to decide why someone is really not feeling comfortable with the decision. You select a common framework that we were just talking about to apply it. And then you come to a consensus, because eventually you got to decide something. So I've seen a lot of organizations and teams get stuck and at a critical mass with no decision making, and the patient gets stuck in that decision and nothing happens. And then you, after you make the decision, you debrief the outcome after you apply it, and then you decide, does this require a policy change? Does this require a clarification of a procedure? Or do we need to go back and revisit this just to make sure that we don't have this happen again? I really believe in review teams, not just for problems that cause some type of risk management situation or a legal ramification or a penalty. Anything that creates that conflict, you should really try to have somebody to come in and moderate if you can't come to a decision. Next slide. So, team-based care, very complicated, lots of layers. How do you do it? Anybody, do we have time? Andrea?
Yeah, I think pose the question to the group. Let's hear some brainstorming or other people's own experiences with how they support difficult decision making.
Anyone have a sort of approach that your team or organization has adopted to mitigate some of the conflict or decision-making quandaries that you would like to share? Or if you'd just like to share one of your own dilemmas that you've currently had that you would like for us to sort of spitball with you and we can problem solve.
Well, I will bring up that, like I said earlier, I have a really small organization out here in rural West Texas, and I think communication for us is key. Anytime somebody has a problem and is in that ethical dilemma and recognizes it, of course, that's key also. But if they recognize it, we meet together and do a quick treatment team meeting just to see, brainstorm together and see what we can come up with and make the best decision. So I think communication is where we really do a good job of mitigating some of those problems.
And if you, thinking back on the sort of steps of how to, come together as a team and make a decision, a lot of those steps involve that open communication. You have to articulate and talk with each other about these and break it down and then come to that consensus using a lot of exchanged information. Yes, great point.
Leslie also asks in the chat, in this vein, any groups out there have ethics committees or a sort of specific way of reviewing decision making?
Anybody need one?
Yeah, I was going to say, I always find it helpful to have kind of a way that I've developed to walk through decision making. And I know actually Cathy and I have consulted many times related to legal, ethical, professional issues. So there's certain ways that we always kind of have a lens, and I always love hearing from others what their lens is. Are there specific questions that you might walk through? So when you do have that consult, do you walk through us in a specific way? Do you say, hey, oh, let me first ask you about this? Just checking in. Do folks have an idea of that?
There are the 4-box method, which we can send you a link to, is one. There are quite a few frameworks out there. But most people will just put it against some type of framework, like evidence-based practice has been a most common one for many because they're held to that for their reimbursement. Yes, absolutely. Having that. Yeah.
Go ahead.
Matt, do you want to say something about that?
Yes, I just often find that there's the reactive orientation to ethical dilemmas that occur. They're occurring in real time, and they're often very stressful. And there's a tendency toward the kind of common senior leadership conversation that is excluding some other parties in the organization who may be really helpful in informing the needs, the issues, the concerns. So do you practice some of the standards that Cathy was describing in terms of that integrated team model?
So Julie says, well, I've worked where we had an ethics advisor. Yes, and so NADAC, NADAC has a really nice ethical guidance sheet that they have on their website, and we can actually put that up as well. And then your Texas Association, very clear ethical guidelines. But I think one of the problems is that, I brought it up earlier, is when you have team members who don't have those as a professional guidance, but they actually are working under the standards of care that are built in your organization, and helping them understand, why and how you're doing something, not just what to do. So don't just, get this fresh release but it's why, and why that's important. So that, yes. Okay, so they have an ethics committee through the state board. That's great.
Julie, thanks for sharing so much about TAAP. I'm actually not sure how the acronym is pronounced, if it's TAP, but thank you for sharing that and for the resources, and to our hub for just really great questions to sit and think about too. Cathy, I want to thank you for a conversation, this great primer on ethical considerations. We're gonna, if questions keep popping up, if there are sort of ethical disruptions you want to throw against the group, use that chat. We'll certainly return to those, but I do want to move on with the remaining portion of our session. Kato, if you wouldn't mind sharing some announcements from the Be Well team. Just to introduce you to Be Well Texas, this is a welcoming environment with caring professionals ready to help people start or continue the journey towards recovery. Be Well Texas is committed to expanding equitable access for compassionate evidence-based treatment and care for substance use disorder throughout Texas. Next slide. Very excited to announce, please do join us for the 5th annual Texas Symposium, pronounced Texas, on March 27th and 28th. That's in San Antonio at the Henry B. Gonzalez Convention Center. Texas is a free event. It includes complimentary continuing education credits and an array of sessions, all relevant to your practice. For more info, visit texas.org. That's TXSUS.org. We'll throw that over in the chat as well. Next slide. Texas is also accepting exhibitor and sponsorship applications. We want you to know 100% of the support we receive provides a free continuing education. 100% of the support we receive is supporting the free continuing education symposium for all attendees, supporting travel grants for experts in the field, and underwriting other event-related costs. Learn more at their website. It's texas.org. The /sponsor Texas. Again, don't worry about capturing that or typing it in. We'll throw the link over in the chat. Next slide. We do hope you'll join us too on Wednesday, February 15th for the next Texas session featuring Dr. Stefan Cortez. To register follow the link there, the texas.org/sessions. We'll throw that over in the link as well, or over in the chat, excuse me. Next slide. And last, we hope to see you at our next session in this series on systems and sustainability. That's February 23rd, 12 to 1 p.m. Central Time. Dr. Leslie Manson on our hub team is going to be presenting on establishing baseline metrics to identify progress in substance use programs. Hope to see you there. Thank you, Cato. And now we'll turn over to our case presentation portion of the session. Jasmine, when you see the case up, go ahead and begin presenting. As a reminder to everyone here, we want to hear as many voices as possible, so keep your comments brief to allow others to join the conversation, but keep those comments coming. This is your time to help your peers navigate any challenges they may be encountering and to use your knowledge to better this community. All right, Jasmine, take it away.
Okay, thanks, Andrea. Absolutely, I agree with that. We do not want to reinvent the wheel, so I am open to any and all suggestions. I feel like everybody is probably smarter than I am in something, and so I'm always willing to learn. So like I said at the earlier, we started Abilene Absolute Recovery Solutions in May of 2021, and I live in Abilene, Texas, which most people are like, where in the heck is that? So our closest large city is the hub of DFW, which is over 2 hours from us. So we serve approximately a 90-mile radius to us. And I have currently 7 employees, including myself. I have 1 medical director and 1 LVN. And then I also have an LCDC that I could not do life without. She has been in the business for over 30 years, and she is fantastic. We have an LCDC intern, we have another LCDC, and then an office manager. So at our clinic, we treat opioid use disorder with Matt, and we have just started actually with buprenorphine, but we started off as a methadone clinic, and we just brought buprenorphine in this month. And so our strongest asset is that we do provide that small town feel, that warm handoff, and we really receive our patients warmly. We love when other community members bring them to us or call and tell us that they're coming, so that we can greet them with a name, because just them getting treatment, it is a small town, and even when they come from far away, and I know this happens in large cities as well, but they are very concerned about who's going to know that I'm seeking treatment. And so we have been really excited to partner with some people in the area to be able to educate them. One of my biggest assets, I think, is being able to go out in the community and talk to, I have talked to everybody that will possibly open their door and listen, from in-house inpatient treatment to probation and parole and things like that, just to educate them on what MAT therapy is. And so we recognized that there was a clinic here in Abilene, but their outreach was lacking. A lot of people didn't know that they existed. And heroin and the causes and problems of that is real near and dear to my heart. My best friend died of an overdose when he was 25. And so we were pretty young. And just knowing that I had children that were coming up in school, they were getting older, they were starting to be exposed to seeing drugs in their school system. And so that's really where my turn came from higher ed into this. And I went into it as a full business model. And with our first patient that came in the door, I just knew that that's where I was supposed to be. She thanked us for being so kind and so helpful and for treating her like a human. And so that spawned me to just go out and educate people further on what we do, and just to continue that small town, small warm handoff family type thing. And so the success stories are what keeps us going, because right now finances are tough. So we're self-funded, for profit. I'm currently negotiating contracts. We got Medicare approved, Medicaid, we're pending SAT visit, and then I will start negotiating contracts with insurance, which will help us financially greatly. We were blessed to get the Be Well grant, and we received that for the buprenorphine in August, but because of staff training and just some things that we had to take care of on our side, we didn't get to start that until this month. But I was really excited. We've already had 2 patients qualify for it. And so that is very, very exciting for us. We know that that's going to be helpful to our patients and patients that haven't even come in yet. So we're really working to build our patient load. And also I feel like there's this void between the people that when they come in, they have, and I call it the void. And I always use this example, and I say on this side, they have the people that they were calling friends, the people that they were using with. And on this side, they have the people that maybe friends or family that are good for them, but that they have burned those bridges. And so there's this gap in the middle of where they're trying to get clean, but they're not maybe in a place yet where they have a good support system. And so we just this month also started Seeking Safety for PTSD and SUD. It's a treatment model. And so we've started those meetings, but ideally I would like to start a nonprofit to fill in that void and to have a place where these people can come and make friends, and just almost like a coffee shop where they can just come and hang out and get to know each other. So that's on my horizon. So we are primary substance use disorder treatment, outpatient, and funding sources and location are our two largest problems right now, the things with which we struggle the most. And so I think we're in the active implementation stage. We have a good budget. We have a good feel for how things are going to go. We know that we are sustainable right now, but in order to grow more, we need some more ideas. And so our challenge comes that Abilene is a small town, and it's small geographically also. It's the population is about 125,000 people, but geographically it's very combined, very compact actually. And so our biggest challenge has been the other clinic that exists basically set themselves right in the middle of town. And so we had to therefore go to the outskirts to have a location, which in some ways has worked out very beneficially for us because we're in a more lower income part of town, which is where the majority of our patients come from. So that's been helpful. But that was a huge problem. And then also that clinic was established first, so they got the block funding for methadone. And so we are not able to get any of that funding. It hasn't been available yet. And it's really difficult because our patients are having to pay for something that at another clinic they can get for free. And our city bus is deplorable, and we don't really have very many Ubers. I literally think there are 4 Uber drivers. Taxis are ridiculously expensive. And so, and the bus route it's long and it's not always on time and it's not super accessible. And so I have used my personal vehicle. They have started calling it the Mafia Mobile, because I go and get patients if they can't make it to our clinic. And so never want somebody to be without, but we also have patients that drive one way over 60 miles to get treatment. And going back to what Cathy had said about some of the problems that existed, just for them, that challenge, and I think it was Cathy who had said that the how rules are changing, and like the 42 CFR is changing. And so it would be really nice if some of those rules that changed about, when patients can earn take homes and things like that, if those would change also, because for those rural people that drive, money is already a problem. They usually don't have reliable transportation, and then trying to get to us, even for the first 30 days with the COVID restrictions lifted, lifting some of those take home medication things, it still is difficult. So that's where we run into problems. We have a lack of funding resources because we are a for-profit. So we miss a lot of that nonprofit openings. And then that methadone block grant is still not currently available to us. And then, like I said, we have a lot of patients who travel really far. So the key strengths that our team brings to this effort, I believe, are leadership, grit, and advocacy. Like I said, I have a doctorate in leadership, and I've taught in higher ed for 20 years. And so I'm really good at motivating my team and encouraging them, because sometimes it's just really frustrating to how long the Medicare process is taken and how long the Medicaid process is taken, and just all the hoops that you have to jump through for that. And then I think our entire team has grit. We have really buckled down, seeing the success stories in our patients, we have actually our first patient is pregnant, is due any day, and she wants me to be at the hospital with her because she doesn't have a supportive family. And the child's dad has COVID, and she called me and asked me if I would come to the hospital, if I would be her person. And so those stories, when we get things like that, that we actually see, she came in and was an absolute disaster, and she's been in our program for over a year, and she is illicit drug free, and she's pregnant, and she has a job, and she's doing well. And so, you know, we have decided that no matter what, we're not giving up. And it's because of patient success stories like that. And then advocacy, we reach out to everyone who will listen. Like I said, there are people in this town, I'm sure, who would rather have closed the door because I wasn't taking no for an answer. I wanted to go and visit with them. I wanted to talk to them. I wanted to tell them, because so many people are miseducated or uneducated about, yes, Carrie, you know, about what methadone treatment or what buprenorphine treatment is. And I found the more I talk about it at the nail salon all the time. And every time I'm there, somebody comes up to me and says, I have somebody who has a problem. I have somebody who needs your services, or can you come talk to my clinic about this? We didn't even know this existed. You know, so it's really, really exciting. And I think that's probably one of our largest strengths. And so today I'm here to talk to you guys about the strengths that you have. You know, our plight is, like I said, transportation for patients, this whole hoopla of trying to get funding, Medicare, Medicaid, and insurance. I'm about to negotiate insurance contracts, and I would love any tips and tricks on any of that kind of stuff. And then I would like to know how you guys, if you have funding sources, if you know of any funding sources that maybe I haven't tapped into, that would be phenomenal. But just overall, I think that us getting this grant for Be Well for the buprenorphine has been a real nice step in the right direction for us. And I guess that's it for me. So I'm ready for commentary on any financial tips and tricks you have on transportation, on how you guys handle those challenges for your patients, and then just best insurance companies, if anybody has had struggles with some or does better with others. That would be wonderful to know. So thank you guys for listening.
Thanks so much, Jasmine. And thank you for the presentation. Really moving to hear your personal experience and then the success stories. We celebrate those along with you and appreciate the personal connection you share with this center. Learning community, I'm turning to you at this point. This is what we'd like to put to you all. Is there feedback you have for Jasmine and this organization about the situation she's presented and about how their services are presented? What feedback do you have for Jasmine? Carrie, I see your hand up already.
Yes. Hi, Jasmine.
Hi.
I put some in the comments. I don't know if you've met with her, but Letty's I'm alumni with Oxford House. So that may be someone to call because she would know a lot of the area, but also it's a resource for people to go to if they need housing. Like we have mommy and me houses and things of that nature. And then I'm a peer recovery specialist. So some of this is out of my pay grade, but I know we work through a lot of the different stuff. So an idea, I mean, I like transportation. When you do get Medicaid, there is Medicaid transportation that helps for those to get to where they need to go. It works. They call 2 days in advance. They just call their Medicaid number on the phone number and ask about transportation.
I did not know that.
Yes, a lot of area. We're actually going to be doing a resource training to train some of our peers how to do that. So, and another thing, just to help raise some money, you can go to the different t-shirt things and make a t-shirt with y'all on it. And everything you don't have to do anything. You design it on there. People can go to that site and buy them, but it's a fundraiser for your organization. And you don't have to be a nonprofit to do that one. So that's just an idea to help you get some in until you can get more, because the outside stuff is a little bit above what I do. So I don't want to talk and give misinformation.
Well, thank you.
You're here. I'm so excited.
Thank you, Carrie. Great feedback. To the rest of the group, other questions or feedback for Jasmine? Jasmine, I wonder if you might, a point of clarification for my sake, could you elaborate a little bit more about the treatment philosophy at the center?
Sure. So one of the things that we, like I said, we pride ourselves on being this warm handoff kind of familial atmosphere. And so every person that I've hired has a direct connection with addiction and recovery, whether it's through their own self or through an immediate family member. And I intentionally did not start out that way. It just kind of happened. And it's been really exciting because those people are able to connect with patients better. And so one of the things that I want to continue is that we as a group, like I said earlier, commenting on what Cathy had talked about, we do treatment team meetings regularly. I do some leadership and team building all the time with my team. And I think that helps. Of course, we're small, but it helps just us to get to know each other and where we're going to come from. And then a lot of patients or a lot of my staff will take that to the patients and be able to get to know them better. I've used not just the Myers-Briggs, did Myers-Briggs for our team meeting, but then there's a much simpler version of just a personality test, like what color are you? And we did that in some of our meetings with our patients. And so getting to know our patients on a one-on-one basis and not just swinging them through the door as fast as we can and medicating them and getting them on their way, but really getting to know part of their lives and building a resource book and helping them helps us keep that smaller atmosphere, that connected atmosphere. And so because we're a small town too, we see our patients a lot out in the community. And of course, ethical guidelines, you're not supposed to speak to them first, but they always will acknowledge us, come up, and we don't say how we know them. We just, we call them neighbors is what we have said. We got that from somebody else in town, Big Mike. He worked with harm reduction, West Texas harm reduction. And so we would just, if somebody asked, we just say, oh yeah, we were neighbors, or this is a neighbor of mine. And so it's just keeping that small connectedness, that feeling, that personal touch, and knowing every single patient by name and getting to talk to them, making them feel like home, I think has been one of my driving philosophies is servant leadership and leading with a servant's heart and doing what needs to be done first, even if it's the hard thing, always doing what is right. And so I lead my team with that servant leadership mentality, and I think that carries over into our patients.
Thank you. Aisha, I see your hand there.
Yes, I had a question for Jasmine, and I'm sorry if I missed, if you've already explained that, but
That's okay.
you did say that there is a similar facility in the area who's providing the same services, and that too for free.
Yes.
That's right. So I'm curious, the patients that you have currently, what made them choose you over them?
I did not address that. And actually, our first patient was the one who, I'm telling you, she's just fantastic. I call her Uno because she's my number one and she always will be. But she came over from the other clinic and she said, I heard that you guys opened. And I said, well, unfortunately, we don't have any funding and all of this. And the first day, what happened with her, and this is not an uncommon occurrence, is she came in, she was she has ADHD also, so she's all over the place. And she said, can I use your bathroom? And I said, sure. And I clicked the buzzer door and let her go to the restroom. And she came back and she was crying. And I said, what's the matter? And she said, you're just so nice. You just treat me like a person and not like a junkie. And I said, you're not a junkie. You are a person. And I said, you're just a girl just like me, just trying to do your best in the world. And she just cried and hugged me. And I have had a lot of patients who say that, and it's our servant leader mentality. It is serving the patients first and treating them like they are the best, like they are the best version of themselves, even when they're not. we treat them with courtesy and respect. And I think that that goes a long way. We get to know them, like I said, we celebrate their steps with them, and it really is great. We will have patients that come in just to visit us, just because they want to come talk to us, not because they're due for counseling or anything like that. So I think that the reason that they come is because of the staff that we have and how we treat them.
It's terrific. Leslie, I see a couple thoughts from you in the chat. I wanted to make sure we got to that. It's articulating, Jasmine, how you're providing a lot more resources and support, and that's important to include when you're going to meet with potential partners, contracts, and pursuing grant opportunities, just to capture that full array. But also a question from Leslie, have you considered telehealth services?
So you're not allowed to do doctor telehealth services in MAT treatment with methadone. And so, no, we can't do that. But we can with the counseling sessions, and my counselors do that as well. So I appreciate that, though.
Yeah, and Jasmine, honestly, you're expressing so much more, something that's so much greater than servant leadership. You are expressing how much, of your heart, and all of your team members are really, part of this and advocating every day. But I wonder if that's really described in all of your services completely. So I'm just putting that challenge in there to ensure that goes on, and that comes out with contract negotiations. Because if you're providing a resource for folks to be able to come back and to be able to have a recovery center where they can hang out and have a safe place to be, where they can be listened to and heard on multiple times during the day, that's additional resource as well, right? So there might be things that you're providing that you might not have identified really in kind of your programmatic or your resources or your descriptors. And those things all can go into those negotiations, and it may even be part of negotiating at a higher rate at times, and why. And then even thinking about how that you can describe as a difference that might occur for you with your services and the neighbors that come in and receive services versus other centers, right? But it also might be helpful with collaborating with other places that provide services. Perhaps they want that resource too. And if you can, with telehealth services, maybe there's a way to have a collaboration that you build with other service centers to say, hey, we do have folks that have times available and have more access to be able to provide supportive treatment, mental health treatment, substance use treatment, whatever that might be, via telehealth. Or we might be able to provide this community access resource in some other way. But there might be other grants, I'm just kind of trying to give you this. There might be other ways you can do it by just kind of looking at what you are providing and making sure you're just reviewing some of your kind of verbiage of your website, right? Of your services.
Thank you. I appreciate that.
Well, we are running up on the hour, and I do want to make sure we end on time. Matt, I'm going to come to you as our lead expert for today. Could you give us a distillation of some of the key points from today's session?
I will, absolutely. Thank you, Jasmine, for your sharing with us. Thank you, everyone else, for participating as well. Just to make a couple of quick notes related to the ethics presentation that Cathy did earlier, right? Ethics related to rights, honesty, relationships, core competencies, respect, autonomy, justice, making sure that we're doing good, that we're not doing any harm. And what we know is that ethical considerations are everywhere, every day. And as Jasmine was talking to us, she shared several places where ethical considerations are alive in her efforts to grow her organization and her work. She talked about maintaining privacy and how to kind of use language to do that, and especially in a town where many people know each other. Talked about some of those issues related to boundaries, for example, with the patient or the client wanting you to go to the hospital, and is that a dual relationship, and what does that mean for you, for her? And that depends on your perspective, your orientation, your kind of practice or nature of your relationship to her. What does that mean? Free versus paid services. There are ethical considerations there when someone can get a service for free and they're being charged for it. And do they know about that free service or not? So respectful language, as you were talking about it, trying to get away from that language junkie that the woman had used in relation to herself. We are all trying to move away from clean and dirty kinds of languages, all the kind of language that we can use to make sure we're helping the individual. So the last comment, Carrie, thank you for sharing from a peer support specialist perspective, a great example of integrated teams and why they're so important. Different perspectives. Carrie had a vision and a perspective that other people in different roles wouldn't have. So thank you.
Really great wrap up, Matt. Thank you so much. I want to thank our Hub team, especially Cathy, for the great presentation. Jasmine, thank you for coming and sharing your story and your challenges and your strengths with us. We all learned with you. We hope to see you at future sessions. Last of all, thanks to all of you for showing up to these sessions, bringing your perspectives and your questions and your strategies. This is what makes this learning community thrive. We hope to see you at our next session on Thursday, February 23rd. At 12 p.m. Don't forget to do that post-session survey that Cato has linked a little earlier there in the chat, and have a wonderful rest of your week. We'll see you soon. Bye-bye.